Welcome to the webinar. We'll get started in another minute or so. We've got some people still joining us. All right, I think we'll get started here. So welcome to the webinar. My name is Shilpa Dogra. I'm a professor at the University of Ontario Institute of Technology in Ontario, in Canada. Today's webinar is being hosted by the Aging Special Interest Group of ISBNPA. So Joanne, I'll get you to flip to the next slide. Thanks. The Aging Special Interest Group, our aim is to build a community of ISBNPA members who are interested in promoting optimal sedentary behavior, physical activity, and nutrition to ensure healthy aging. So the Special Interest Group was formed a couple of years ago at the ISBNPA conference. So this webinar is one of the webinars that we'll be hosting this year to sort of help encourage aging researchers to come together and learn a little bit more about aging research that's being done by ISBNPA members. There's some information provided there, as well as contact information if you'd like to join the Special Interest Group mailing list. We will be using Twitter today. You can use the hashtag of aging_SIG to live tweet Joanne's talk that's coming up. So today's talk is on mobilizing research data to clinicians, the public, and policymakers. It's a case study of dietary sodium reduction. The talk will be given by Dr. Joanne Arcand, who's a colleague of mine from the University of Ontario Institute of Technology in Ontario, Canada. Next slide. So just a couple of housekeeping pieces before we get started. All of the participants are muted at this time. You can write questions as we go along in the Q&A box at the bottom of your screen. If there's a time where you'd really like to ask a question verbally, you can raise your hand or in the queue. And at the end of the session, we may unmute your speaker for you so that you can ask the question directly to Dr. Arcand. So without further ado, I'm going to hand the speaker over to Dr. Arcand, who's our speaker today. Just a brief introduction for Dr. Arcand. As I mentioned, she's an assistant professor in the Faculty of Health Sciences here at the University of Ontario Institute of Technology. She's also a registered dietitian and has a PhD in nutritional sciences from the University of Toronto. Dr. Arcand has expertise in clinical and population health aspects of cardiovascular disease prevention and management, and also has significant knowledge translation and implementation experience. Today, she's going to speak to us about some of these experiences. So without further ado, I'll hand it over to Dr. Arcand.
Okay, thank you, Dr. Dogra. So today I wanted to start this talk by looking at the knowledge to action cycle. And now this knowledge to action cycle is really indicating the entire knowledge pathway from synthesis through to implementation, otherwise known as knowledge translation. Now, as researchers, we're typically very comfortable sitting in the middle here, looking at knowledge inquiry through the development of primary research data, knowledge synthesis, considering meta-analyses and systematic reviews, and the development of knowledge tools and products like decision-making aids such as clinical practice guidelines. But really, as scientists, we're trained in this area to develop knowledge, but unless deliberate actions are taken to mobilize this knowledge, the impact of the knowledge created is not going to achieve its full potential and be able to create change or solve the problems that we intend the knowledge that we create to achieve. So the objective today is to really take a case study approach to describe how our research team mobilized data that we created to clinicians, the public, and policymakers to promote collective action in reducing the dietary sodium intakes of Canadians. So the intent of this talk is really to give researchers ideas in how they can apply similar concepts to their area of expertise, and for any knowledge users listening to get ideas of how they can support researchers in mobilizing the research data to different stakeholder groups. So as an outline for today's talk, I'm going to review the health and behavioral and global drivers for action related to dietary sodium, and review the sodium reduction strategy that was developed for Canada. I'll then talk about some of the research that our team developed as part of a specific funding program for dietary sodium research. And then the last part of the talk will describe the development and implementation of a knowledge translation plan that we developed with our knowledge user collaborators. So before moving too far into this talk, I wanted to just clarify some terminology. Sodium is often referred to as salt, and that's okay, but they're two different things. So sodium is a naturally occurring mineral or element, whereas salt is sodium chloride. So the recommendations for salt and sodium are slightly different. Salt and sodium can be used interchangeably, but throughout this talk, I am going to talk consistently about sodium. So in thinking about the health drivers for why we need to reduce dietary sodium intake, so this is recent global burden of disease data looking at dietary risk factors in Canada that lead to mortality. And high sodium intake is the top dietary risk factor as it relates to mortality, which is largely related to deaths from cardiovascular disease. These deaths are largely related to the effects that sodium has on blood pressure. So this study that I'm referencing here is the study that actually was used to generate the World Health Organization guidelines. And they looked at high quality research. So it was research that had achieved specific methodologic and study design criteria. And so only the highest quality research was used to generate risk estimates as well as the WHO recommendations. And what they found in that study was that in randomized controlled trials, when we're looking at sodium reduction compared to a control group, systolic blood pressure reduces by 3.14 millimeters of mercury and diastolic by 1.8 millimeters of mercury. On a population level, if we're to reduce sodium intake, blood pressure by this degree, we would have substantive improvements in population health. They did some subgroup analysis in this study. There was a greater reduction in blood pressure among those who had the highest blood pressure levels, such as those with hypertension. And the more that sodium was reduced, there was a greater blood pressure reduction. And importantly, and one of the public health messages that we have is that reducing blood pressure through sodium reduction is healthy both for people who have a normal blood pressure and high blood pressure. So sodium reduction is relevant for all individuals. When we look at morbidity and mortality estimates, this same study that applied strict quality criteria found that a high sodium diet was associated with increased risk of stroke, fatal stroke, as well as cardiovascular mortality. Now, these are from observational, from cohort studies. In particular with cardiovascular mortality, similar estimates have been seen in meta-analysis of randomized controlled trials. So how much sodium should we be consuming? There's different sources of recommendations. The one we have is from the World Health Organization, which is less than 2,000 milligrams of sodium per day for adults. And the other recommendation we have are the dietary reference intake. So these are recommendations established by the Institute of Medicine. The dietary reference intake recommendations have two levels. The first is an adequate intake level, which is the level that a person should be aiming to consume. And then there's a tolerable upper intake level, which is the level that people should be aiming to be below. So any sodium intake beyond the tolerable upper level substantively increases risk for adverse health effects. So the tolerable upper level for most, well, all adults is 2,300 milligrams per day, but adults should be aiming for 1,500 milligrams or less if an individual is older. So this is Canadian data on how much sodium we actually consume. The mean intake of sodium in Canada is 2,700 milligrams a day, just over that. This is an analysis, this graph is an analysis of sodium, the proportion of people exceeding the tolerable upper level of 2,300 milligrams across various age and gender groups. So the yellow bars being children, the blue bars being females, and then the red bars being males. And what we can see from this data is that males in particular consume significantly more sodium than females. And this, the proportion exceeding the tolerable upper level varies across age groups as well. And that's largely linked to caloric intake. So we know that older individuals don't consume as much food in a day, and therefore they're not consuming as much sodium. And that's the main driver for that. We also know that individuals who are older also have health conditions that might necessitate low sodium intake. So a common misconception is that a major source of dietary sodium comes from sodium added at the table or during cooking. And what this recent data shows is that the majority of sodium in the diets of people in developed countries is actually coming from foods that are purchased outside of the home, in particular processed and restaurant foods. And this is important to know because any intervention, public health intervention aiming to reduce the amount of sodium in a population is going to have to target the food supply so that consumers naturally consume lower sodium in the food that they usually eat or have lower sodium versions available to them. This is very recent data that came out last year from Canada that looks at the top sources of sodium intake in the Canadian diet. Though this is specific to Canada, it's actually also quite similar across other developed countries. Bakery products, usually in the form of bread, is the top contributor to sodium intake. And in Canada, that's followed by mixed dishes and processed meats. So you might be thinking, well, bread isn't really a high sodium food. Bread in itself only contains moderate levels of sodium, but because we tend to consume so much of it in a day, it ends up contributing a lot of sodium overall. Whereas mixed dishes and processed meats, cheeses, and soups, the next 4 top contributors, they're what we would call highly dense in sodium. And so we may not consume those foods as often, but when we do consume them, they're giving us a lot of sodium in each portion. So what's being done to target high sodium intakes in developed countries and really across the world? The World Health Organization set 9 global targets that are hoped to be attained by 2025. And these targets were set to reduce premature mortality from non-communicable diseases by 25%. And importantly, dietary sodium reduction or salt reduction is one of these 9 targets. And the goal is to reduce population sodium intake by 30% by 2025. And so this type of leadership at a global level has then led other countries worldwide to adopt these public health priorities. Importantly, this dietary sodium reduction as a public health priority yields such health and economic benefits that it was considered to be a best buy public health strategy by the World Health Organization. And so this is a figure that was created showing different salt reduction strategies all over the world. This study that was published in 2015 found that 85 countries all over the world have population-wide salt reduction strategies, and I would suspect that that's more now given the increasing emphasis on salt reduction. So in Canada, we were, in the Canadian government took this on and formed a multi-stakeholder sodium working group that included government, healthcare professionals, food industry, health organizations, and other important stakeholders to develop a sodium reduction strategy for Canada. So this is a real implementation strategy in order to lower the sodium intakes of Canadians. It was published in 2010. The ultimate goal, or the interim goal rather, was to reduce it's to have 50% of the population consuming less than 2,300 milligrams, so that's the tolerable upper limit, per day by 2016. So over a 6-year period, that was the goal, with an ultimate goal of having the majority of the population consuming under the tolerable upper limit. So to achieve this, the Sodium Working Group developed 27 recommendations that fell within the area of the food supply, education and awareness, and research. And all of these 3 prongs were to be grounded in a monitoring and evaluation approach so that we could see the sort of progress indicators and then, through to the overall health outcomes or health benefits that resulted from the sodium reduction strategy. However, importantly, 3 months after the strategy was published and adopted by the government, that sodium working group was disbanded, and no monitoring evaluation program was developed. So it hadn't been developed by that point, and then it never was developed, unfortunately. So this was an example of how a change in political mandate and environment can impact public health policies. So despite this slight setback, the Canadian Institute for Health Research, which is our main funding agency in Canada, launched a strategic research funding program to fund grants for sodium and health. And so our research team submitted an application for this, and we were awarded a grant that focused on examining sodium levels in the food supply, specifically looking at packaged and restaurant foods, and then to conduct some Canadian consumer research, which focused on knowledge, attitudes, and behaviors, as well as consumer understanding and use of food labels. So this is our research team at the University of Toronto. Our team was headed by Dr. Mary Labbe as the principal investigator. At the time, I was a postdoctoral fellow and worked very closely with my 2 colleagues, Christina Wong and Mary Scorbadakos, who were both PhD students at the time. We were supported by Dr. Wendy Liu for data analysis. And an important part of this team was Dr. Heather Manson, who was our designated principal knowledge user. She is based out of Public Health Ontario and with extensive expertise in dissemination and implementation of research. So before going forward, I wanted to talk a little bit about the 2 types of knowledge translation. The first is end of grant knowledge translation, and this is the type of KT that most people are aware of. We generate findings, and at the end of the research progress, we make plans for how to use the data generated. So those plans might include educational materials, they might include media releases, and very traditionally, it's peer-reviewed publications and conference presentations. But rather, we're trying now to integrate more and more take an integrated KT approach. And the integrated KT approach includes, involves knowledge users throughout the entire research progress. process. So researchers form partnerships with knowledge users, and together they generate research questions, specific analyses that would be important to the knowledge user. And the real relevance of this is that the data that's generated is more relevant to end users, and it's much more action oriented. So the data that is developed can actually be used to solve important problems or generate solutions. And so, you know, as researchers, we always intend that for that to be the ultimate goal of our studies. But by taking an integrated approach, we can potentially even have more success with that. So we took an integrated KT approach as part of our research program in dietary sodium. And the way that we did this was by developing a Canadian Sodium Knowledge Users Advisory Committee. So this advisory committee included representatives from the government. So we had Health Canada, we had representatives from Health Canada, people from the Ministries of Health from several provinces, Public Health Agency of Canada, and then we had several professional and health organizations involved. Key stakeholders being, you know, the Canadian Public Health Association, Heart and Stroke Foundation, Dietitians of Canada, and Hypertension Canada. So these are health professional groups, etc. And then we had some individuals, specifically Dr. Bruce Neal and Norm Campbell, who have extensive experience in this area and expertise in sodium and could provide their individual perspectives. So to sort of operationalize this, what we did throughout our grant period is we had biannual meetings. So twice a year, every 6 months, we would get together. If we were starting a new project, we would present our project ideas, our hypotheses, and then this knowledge users group would inform that. So if there was specific analyses that they wanted to see, we could build that into our analysis plan. And then often we would, when we finished a study, we would present our findings to this group again, and they would help us by forming subcommittees, generate a plan for dissemination. And this was incredibly effective and helpful to us in ensuring that we maximized the reach of our messages. So I'm going to talk now about some of the data that we generated, just to give you a little bit of context about some of the messages we were getting out there to the public and other stakeholders. So as part of the sodium reduction strategy, Health Canada published a set of benchmark targets. Now these benchmark targets were for packaged food, so food sold in grocery stores or other food outlets where you can buy food. And these targets were designed to facilitate an overall 25% reduction in sodium within food. Now, they took an incremental approach. So as you can see in blue, there was 3 phases. So each different food category had different levels. And the incremental approach ensured that small reductions in sodium were occurring over time so that consumer acceptance of products was not being impacted significantly. The idea is that by phase 3, 2016, the goal would have been achieved, so that approximate 25% sodium reduction would have been achieved. And so what we did is we developed a database of packaged foods, a very large database, and we measured the changes in sodium content in Canadian foods over time. And this is some of the data that we found. So this was a midway evaluation of Canada's sodium reduction strategy. And what we found was that when we looked at mean levels of sodium and how the distributions in sodium were changing from 2010 to 2013, that there was no significant change in most foods. So 82% of food categories had no change in sodium. we found that 16% had significant reductions in sodium. So in knowing that 16% of categories had significant reductions in sodium, it's important to think about what those food categories were. So if it's the foods that are contributing the most sodium to the Canadian diet that are changing, then this could potentially have an important public health impact. And what we did is we looked at those food categories to see which ones were changing. What we found is the following. So if we look at the percent reduction in sodium here, imitation seafood, condiments, breakfast cereals, canned vegetables, and plain potato chips were the categories that made the most significant changes, which were actually quite meaningful because they reached almost 20% just within 2 to 3 year period. When we look at these red arrows, so these red arrows are some of the top contributors to sodium in the diet. So looking just very specifically at packaged bread products, the top contributor of sodium only changed 6%. So there was a statistically significant difference, but when we look at the potential public health impact of that, it's likely going to be not as much as what we would have expected. So within the following 3 year period up to 2016, it's significant improvements would need to be made if packaged bread products were to reach the desired 25% reduction. So the other analysis that we can do with this data is to look to see how many foods are meeting the sodium benchmarks. So the black color here is the proportion that are already meeting the sodium benchmark targets. And the red is the proportion of foods that are not meeting any target. So these foods have excess levels of sodium that aren't even reaching one of the phases. And what we found that over a 3 year period, there is a slight shift in the proportion that were exceeding the benchmarks, and a slight shift towards those that are meeting the benchmarks as compared to those that were not. So some progress, but again, at a midway point, we probably would have expected more if we were to be on track to meeting those goals. The other analysis that we did, my colleague Mary Scorbidakos, she looked at restaurant meals. So this is data for single restaurant meals, and restaurant foods contain very high levels of sodium. Here you can see in 2010 at baseline, approximately 1/3 of foods were exceeding the sodium recommendations. And now this is for just one meal alone. So this has a significant impact on sodium intakes of Canadians. What we found is over a 3 year period, there was practically no change in the proportion of foods that were exceeding the UL. So there wasn't an increase, but there also was no decrease amounts of sodium in the foods sold in the meals sold in restaurants rather. So that was some of the food supply messages that we had. In terms of education and awareness, so that consumer research side of our research program, also in alignment with the awareness and education prong with Canada's sodium reduction strategy, we actually went and we conducted a nationally representative survey across Canada to determine knowledge, attitudes, and behaviors related to dietary sodium. We found overall that Canadians were quite engaged, that 59% reported trying to limit sodium intake at some point. We did some subgroup analysis and found that as people aged, they tended to be more likely to reduce the amount of sodium in their diet, or taking action to reduce the amount of sodium in their diet. And this could be related to the fact that they've developed health conditions like hypertension or heart failure. We found no difference between men and women. And again, not surprisingly, when we looked at people who had hypertension, a diagnosis of hypertension, they were about 3.5 times more likely to be taking action to limit their sodium intake as compared to those who have normal blood pressure. A few other questions we asked. Among those who were limiting their sodium intake, why were you limiting their sodium intake? We wanted to know what some of those drivers were for them to think about taking action. We found that 86% were trying to limit their intake to improve their overall health because they heard that they should. 38% to manage a current health condition. And then only 26% because their healthcare provider had recommended it. Importantly, in this group, 46% thought that their sodium intake was low because they were not adding salt to their food. So this reinforced our previous knowledge that there are misconceptions among the public related to the sources of dietary sodium. And then finally, among those who are not limiting, we wanted to know why not. And a large majority said because they have low or normal blood pressure. So we know this is not, there's no data to support that, particularly those with normal blood pressure. So again, that's another misconception that could be addressed. Others because they thought they were in good health. And then a third because their healthcare provider had not recommended it. So another sort of area for action there is potentially educating healthcare professionals to promote dietary guidance around dietary behavior change in clinical practice. So that concludes some of the data that we created as part of our grant. Now, at the end of the grant, when thinking about developing a KT plan, these are some of the questions that one would ask themselves. I drew some of these questions from Melanie Bartwick's model. It's a KT planning template. She's based out of the Hospital for Sick Children, but there are several of these templates that have been created. There's innovation to implementation. Health Canada has a KT planner as well. And these are some of the key questions that one must ask themselves when developing a strategy. I'm going to walk you through our dissemination and implementation strategy and how we addressed things like what are our messages, who is our target audience, what kind of goals are we trying to achieve, and then what types of strategies would we take. So when thinking about our KT messages, so these are just some sample messages that I created for the purpose of this presentation. What we did, our process was to work with our Sodium Knowledge Users Advisory Committee to refine the key messages so that they are appropriate to the target group. So our food supply messages for the public would be different than the food supply messages for industry or for government. And the same is for the consumer research messages, or the messages that came out of the consumer research that we conducted. So there's some health professional organizations that are key stakeholders to that knowledge, as is the public. So we worked with our knowledge users group to develop these. We then refined who our target audience was at the same time. So we know that for population-wide dietary sodium reduction, researchers in terms of science would be an important stakeholder group. Health and consumer advocates are an important stakeholder group because they influence the public, but then they can also influence government to impact change. Government was, being a creator of policies, particularly at the federal level, where regulatory action can be taken. The food industry is a very natural knowledge user for our work as well. So we had messages generated and specific methods generated for each of these groups. So in terms of how we reach these groups, the approach varied. Traditionally, to reach government or industry or researchers or healthcare professionals, peer-reviewed publications and conference presentations are usually considered. We were able to open up other opportunities for meetings, specific meetings at food industry meetings or sectors rather, like the meat industry or Dairy Farmers of Canada, for example. We also engaged opinion leaders and champions. So we have some really strong champions on our knowledge user team, and they were really critical at incorporating some of our data and our messages into presentations or media opportunities that they individually may have had. And then to the public or other clinical or public health knowledge users, we directly reached out to some of those users, particularly healthcare professionals and public health professionals. We use mass media and social media campaigns to reach the public. We developed innovative tools. Some of this I will review with you in the upcoming slides. And then we leveraged off of existing initiatives. So we're going to dive into some of these things now so you can see specifically what we did. So overall, over the grant period, we published 14 peer-reviewed papers in journals. We published 13 abstracts, which were presented at national and international meetings. And these meetings were typically focused on nutrition, hypertension, or cardiovascular disease. These are some of the presentations that we conducted, or the places where we conducted presentations. So because sodium reduction is a national, it's a national strategy, a national initiative, these national meetings were really important. We gave several presentations to Health Canada, the Canadian Public Health Association, Hypertension Canada, Dietary of Canada, and we were able to reach multiple stakeholders through all of these presentations. Another area where we were able to present to members of Parliament, which was an exceptional way to reach decision makers. But these talks reflect symposium, inviting presentations at meetings, as well as conference abstract presentations. And you can see similarly, we did several provincially. So we did an interprovincial and territorial multi-sectoral engagement meeting presentation, which was critical because we were able to reach some decision makers there. And then internationally, sharing our experience with our other colleagues around the world is another way for us to share some of our data, but also obtain feedback from others. So those were the presentations that we gave, the publications that we published and presented. And one challenge that we were thinking when we were going through this was, how can we get this data out to the public? Because we know that when the public knows sort of personalized information about the sources of their personal sources of sodium or the amount of sodium that they consume, that it can be a real driver for behavior change. And so individuals will start changing their choices to be healthier, lower in sodium, and as another way for individuals to take personal action. So in considering all of the ways that we know how to assess sodium intake in the diet, you can see these here. You know, they're quite burdensome: 24-hour urine collections, food records, dietary recalls. All of these methods that take time. They require analysis by, biochemical analysis or through sophisticated software programs, and they're not necessarily feasible or timely. And so we came up with this idea with my collaborator, Dr. Doug Manuel at the Ottawa Hospital Research Institute, to create this tool called the sodium calculator. And the sodium calculator, it's a brief, rapid dietary assessment tool. It's based on Canadian data. So it's based on our national intake data, as well as the sodium content of food that we collected as part of our grant. So our grant, the data from our grant is directly tied into that sodium calculator. So it takes about 5 minutes to complete. It's 23 questions about packaged foods and restaurant foods. And it provides the user with immediate feedback on the estimated amount of sodium they consume in a day, a comparison to the recommendations, As well, it ranks the top sources of sodium intake. And so this for an individual can be, can give them a sense of how they can start thinking about changing their dietary behaviors. We've also had several clinics in Canada and the US start to integrate this into clinical practice. So we can, so a physician or a nurse can guide their patients in the brief advice that they might give in reducing dietary sodium. And that's actually now evaluating that as part of my research program. And just in a small pilot study that we did, we found that the calculator would result in an improved number of people correctly recalling the dietary sodium recommendations. It increased the number who thought they consumed too much sodium. So most people in our cohort were consuming sodium above the recommendations. And they were finally able to realize that. And then finally, the number interested to taking action and reducing their personal sodium intake increased. So it could be an effective tool. So one of the other things that we did as part of our knowledge translation, end of grant knowledge translation, was to leverage off of existing programs. And the World Action on Salt and Health, or WASH, has a week in March that is called Sodium Awareness Week. And there's lots of tools that are developed and social media campaigns that go along with that. So what we were able to do, we actually took advantage of Sodium Awareness Week because some of our papers were coming out around that time. We worked with the journals to coordinate the publication of our articles leading up to Sodium Awareness Week and during Sodium Awareness Week, which was very effective in garnering media attention. We worked with Public Health Ontario to refine our key messages related to our studies. And then the University of Toronto sent out a press release. So during this 1 week, we obtained multiple television broadcast interviews, syndicated radio coverage across the country, as well as several print publications as well. And as you know, as media is being published, it gets shared, and so the number of impressions increases substantially. And so our KT partners actually, in the case of just giving a specific example to Sodium Awareness Week, we all pulled together and disseminated the products that we had created for Sodium Awareness Week. So these partners here, Public Health Ontario, the Heart and Stroke Foundation of Canada, Dietitians of Canada, they all shared the messages through social media. They engage their members. So some of these memberships are quite large, like Dietitians of Canada. Several of them put out press releases around Sodium Awareness Week, and then in some cases generated educational materials for their stakeholders. So this really ensured that we could get as much reach as possible. And so specifically for the sodium calculator launch, I was consulting with the CBC, which is the Canadian Broadcast Company, our national broadcaster in Canada, for this program called Marketplace. They were doing an article, a whole episode on sodium. And so as part of this, we had the opportunity to launch the sodium calculator as part of that program. And so that really resulted in, lots of hits and really a nice flurry of activity around the sodium calculator. So again, leveraging off of and taking advantage of very strategic opportunities allowed us again to achieve maximal reach. So in addition to this, in the House of Parliament in Ottawa, private members bill was introduced by Ms. Libby Davis. And this private members bill focused on re-implementing the sodium reduction strategy for Canada. So it was really intended to reactivate Health Canada and government to give them a mandate to implement all aspects of the strategy. And so this was put forth to there was going to be a vote in the spring of 2013. And so we had the opportunity, this was actually just before Sodium Awareness Week, we had the opportunity to go to Parliament and present to a group of members of Parliament and share with them the sodium calculator. So you can see me there with the sodium calculator. Carolyn Bennett is a member of Parliament. And so it was a very unique and very interesting and fun opportunity, I would say. And so, you know, that was in 2013. We did have a change in government. This is the mandate letter that was given to the new Minister of Health in November of 2015. And I would like to think, as a result of some of our, you know, ongoing efforts and sort of pushing to include sodium as part of public health efforts in Canada, reducing salt in processed foods was still determined to be a key priority for the new government, which was really nice to see. So that concludes, you know, that one research grant. I wanted to give you an overview of continuing efforts. So we actually have a team, it's an international team of researchers, sodium researchers, who regularly conduct knowledge synthesis reviews through a program, through a Science of Salt advisory group at the World Hypertension League. And I'm a co-chair of this along with my colleague at the WHO Collaborating Center on Salt Reduction at the George Institute in Australia. So this team regularly, on a weekly basis, we search the literature for all new articles that are published related to salt. And then we have a newsletter. So if you sign up for this newsletter, you will get a weekly summary of the articles that any new research that has been published. So what we do is, on an annual or biannual basis, we will publish the results of this literature search. So this is an example of the most recent one that was published. We do put quality in criteria behind this, behind the research that is critically reviewed. So we're critically reviewing the highest quality research on sodium. So some of the conclusions that can be drawn from these reviews can be considered for policy and practice. And so, yeah, so these are ongoing reviews that are published. And so that really, that summarizes or concludes my presentation for today. So in considering some of the factors that led to our KT success, so implementing KT, like a true integrated and collaborative end of grant KT strategy, can be overwhelming for the average researcher. But these are some of the things that I felt were probably really helpful in our success. First, there being a sound scientific basis. There has been some controversy around sodium, but in considering the methodological quality of some of the newer research that comes out, there continues to be a sound scientific basis for sodium reduction. Targeted research funding allowed us to continue or create a program to inform future policies and programs related to sodium reduction. And indeed, we were able to do some of that work that Health Canada would have loved to have done if there was a political mandate for. So that was really nice that we could keep it afloat until Health Canada could take it on. Developing the KT Advisory Committee was paramount. The involvement of Dr. Manson and all of our highly engaged partners were critical to achieving maximal reach and potential of our data. And it was such a lovely experience and great group of people to work with. And then finally, we were willing to learn how to do knowledge translation and willing to commit the time. So sometimes we just get so busy that knowledge translation doesn't necessarily seem to be a priority, but we did make it a priority, and it was really helpful to have the support of so many people. So because there were so many people involved, it made for lighter work on our behalf. So there was others carrying the torch with us. It is important to note that we didn't receive funding for knowledge translation as part of our grant. It was time that we took as researchers, so there was no hired staff to work on knowledge translation. And it was through the generous in-kind support of our KT Advisory Committee members. So with that, I will conclude this presentation, and I'm happy to take any questions that you might have.
Thanks, Joanne. That was awesome. I've learned lots about knowledge translation today and how I can try and integrate it into some of my work. Just before some of the questions start coming in, maybe I can ask you to talk a little bit more about what it was like to engage some of the actual participants or the people who would need to use the sodium calculator. So what was their reaction in terms of engaging in research and their willingness to commit time to these types of efforts?
Do you mean, are you referring to the development of the sodium calculator or the users?
Yeah, I mean, the whole process, like, did you involve older adults or people with, hypertension throughout the process, and what was their willingness to engage?
Yes, so the iterative process, we would create a version of the sodium calculator and then go and test it. So there was we were consistently collecting feedback. It's really important to note that we did engage some older adults in the process, as well as some younger. So we, especially, and even now, it's very important that you say this because we're in the process of updating some of our reports to be more user-friendly. And so, yeah, so people were, patients, end users were involved. Additionally, we involved dietitians and other healthcare professionals to make sure the language was at the level that it should be at and whatnot. So
I'm a bit curious too. So just from some of my experiences working with older adults, there's almost two cohorts, some who are really tech savvy and some who automatically sort of walk away from it. Did you experience any challenges there with some of the participants?
Absolutely. We actually have some recent data on this. So about 25% in primary care, people with high blood pressure, about 25% had difficulty using it. And that's mainly, so the way that we've been administering it is on the largest size iPad, which I think is 8.5 by 11 size. We have a pen, which helps with the implementation in terms of touching the screen. But about 20 to 25% did have significant difficulty with it, which is one of the reasons that we're going back right now to try to make it as user-friendly and easy to use as possible.
Oh, that's good.
But otherwise, the other 75% could sort of make their way around it. Some very savvy, and then others sort of somewhere in the middle.
Yeah, it's interesting. There's some older adults who, know technology better than I do, but some of them, not that they don't know how to use it, they really don't like it, right? So it's almost like you need to have options available sometimes.
Right.
I don't see a whole bunch of questions pouring in. So I'll give you guys a chance in the audience to type your questions in. Any other comments with regards to sort of like the benefits of engaging groups throughout the process? Did it, I find sometimes it's a bit challenging because it adds to your timelines. Did you see any other benefits or challenges along the way that you can maybe speak to?
Well, I think, there's absolute benefits to including as many stakeholders as possible. So in total, in our Sodium Knowledge Users Advisory group, we had about 20 to 25 individuals. And so the benefits of having such a large group was that we could then break off into subgroups and develop messages for certain target audiences, depending on the types of individuals who are in our knowledge users group. So for example, Public Health Ontario might partner with Dietitians of Canada and, someone else to create messages for healthcare providers. And then, the dissemination was easy because we had a representative from Dietitians of Canada who could then distribute those messages to their membership, which is what they offered on several occasions.
And what about making connections with the government? Like, was that challenging, or was your network able to sort of help build those connections?
So we were very fortunate to have connections to the government because Mary Labbe, who is the PI in this grant, had worked for the government for many years. So for her first career was in the government, and she had connections there. She was the co-chair of the sodium working group. And so for her, because she knew so many people, it was relatively easy to assemble such a large committee. But one of the ways that we discovered this can happen is experts of knowledge, or groups of knowledge users or experts can form fairly quickly through a snowball effect. So if you're talking to somebody, they may have another perfect person in mind who would positively contribute to the group. So sometimes just having those one-on-one conversations with people is the best way to build these kind of committees, because it builds a network, and so people start to form greater synergies through personal interactions. So never hesitate to pick up the phone. I talked on the phone a lot. I abandoned email at one point because there was so many benefits to just picking up the phone to calling people.
That's a good point. I don't see any questions coming in, so I think we'll wrap it up there.
Okay.
Thank you so much for doing this. I really appreciate it. I learned lots about knowledge translation and how I can start to integrate it into some of my own work. For the people who are still on, the webinar will be posted if you'd like to view it again, or if you'd like to share it with folks you think might be interested in some of this content. A reminder, you can check out some of the tweets using the hashtag aging_SIG. And I think that's it from us here. Have a good one.
Bye-bye. Thank you so much, Joanne, for this.
You're welcome. That was good timing.
Okay. So bye-bye. I'll end the meeting now, the webinar now.
Okay.
Talk to you later, okay? Bye-bye.
Okay, bye.